welcome to another intensivecareathome.com podcast. My name is Patrik Hutzel. I'm the host of the show. Intensive Care at Home, we provide tailor-made solutions for long-term ventilated adults and children with tracheostomies, and we also provide tailor-made solutions for hospitals and intensive care units whilst providing quality services for our clients. And we also provide services for our clients on BIPAP, CPAP, home, TPN. So welcome to the show. And today I've got a very special guest here. I've got Dionne Essenstam here. Dionne, welcome to the show.
Thank you, Patrik.
Thank you. Let me introduce Dionne to you. Dionne is our Queensland service manager. Dionne has started with us in the last few months to set up similar services than that are already successfully operating in large parts of Victoria and also in large parts of New South Wales. Mm-hmm. Again, Dionne, welcome to Intensive Care at Home, and thank you for making time to talk to me on this podcast today. Dionne, tell us a little bit more about your experience and how you ended up working for us and what we're planning to do in Queensland going forward.
I would have to say I'm very lucky to have found this position with you guys. It's a culmination of all my years of experience as an intensive care nurse. I feel like I'm using all of those skills with the role that I have with Intensive Care at Home. So thank you for that. I am a bit older than I'd like to be. I've been a nurse for 30 years. 25 years of that was in the paediatric intensive care space. I've pretty much done almost every role in the intensive care unit right up to being the nurse unit manager before the facility I worked at closed to merge with another facility. I have opened up a number of services over my years, new paediatric services, and had also a position as a nursing director with one of the largest HHSs up here in Queensland Health. So I bring with me my ICU nurse's hat, but I also bring with me some management skills and capabilities that I think that we need to try and build our service up here in Queensland.
But you're also bringing the experience especially from the pediatric ICU world, where you would have seen kids stuck in ICU long term. You would have dealt with trauma of parents firsthand.
Yes. Absolutely. There was always at least one patient in the ICU who was our resident, who used to live there because there was no alternative. There was no way home without burdening all of the care responsibilities on parents, and who were often absolutely traumatized and stressed at the worst time of their world, that their child has fallen ill and has a critical illness that is likely going to be long-term and ongoing for these resident PICU patients. So absolutely, I've seen firsthand the damage that responsibility can do to a family structure. And it's really part of the reason I'm so excited to be working with Intensive Care at Home. I feel like we offer these families a way out, a way to go back to almost the normality that they used to have whatever got them into that horrible situation. I firmly believe that we save relationships and families by assisting with that burden of care in the home space, so that mums and dads can go on doing the normal things that they would do and going to social school events with their kids and just participating as a family as best they can under their new definition with their child that has obviously got something that's led them to needing us to care for them in their home.
Look, I think it's no exaggeration when I'm saying we have transformed lives, and I mean that in every positive way.
Yeah, absolutely. I completely agree.
Okay. And for anyone watching this, that's, a hospital employee, a hospital executive, an intensive care professional, doctors, nurses, physiotherapists, allied health, whilst, our goal is first and foremost to improve the quality of life for our clients as well as for families. We can help you help you eliminate your bed blocks, especially in ICU, but also on some of your respiratory wards. We can eliminate the cost for a hospital. When I say eliminate, the majority of our clients are now funded through the NDIS, through the National Disability Insurance Scheme. So there really is no cost for the hospital. It's a win-win situation all together.
And it's the revolving door, Patrik, that I feel like that we're closing. Families who were traditionally sent home to be the primary caregivers, in a moment of deterioration or change that's unexpected, the first things these families are advised to do is come straight back to the hospital, and thus the revolving door occurs. By having a qualified, experienced intensive care nurse at their bedside, not only can they help with that deterioration, but they can generally recognise and prepare or even prevent that deterioration from happening just simply by using the nursing skills that they've developed over years and years and years.
Absolutely. It's quite literally, we are bringing the intensive care into the home to stop that revolving door, which not only keeps ICU beds empty, but also ED beds, ED admission bays empty. It's a win-win altogether. What have you seen, in terms of, and I have seen it, whether it's in the adult world, but also with some of our pediatric clients, family structures can be very fragile in those situations. And we've certainly seen our fair shares of family crisis and leading or as a result of those long-term stays in ICU. And, I'm sure you've seen families breaking apart because of that. And, our goal is not only to improve the quality of life, it's also to keep families together, really.
Yeah, absolutely. And even just things like gainful employment. Like, I've looked after a pediatric patient whose mother was by the bedside of, for 12 to 14 hours a day, and then would go home to care for the other children after childcare arrangements were finished. And the father would then come and stay by the bedside all night, but then in the morning get dressed in his business suit and go off to do his company directorship role, which, I think in the short term, most employers would be kind enough to, allow and adjust for these kind of situations. But this child had a lifelong chronic illness that was exacerbated, and, eventually he needed to leave his job. That took the financial burden onto the family. It put more strain onto the family because, obviously things were a lot harder and a lot tougher when there was no gainful employment for the family to even fund this sort of bedside vigil that they needed to do. And there was no alternative for this young man to go home receiving especially the airway care that he needed while he was in that acute phase of his deterioration. It was awful. It was absolutely awful. Yeah.
Look, I have another example there. We have a current client where, initially when we started out, there wasn't any 24-hour care, and the child, it was a child at the time, was more or less living in ICU, and the dad couldn't work either. And, now 24-hour care has been in place now for a number of years, and the dad is now gainfully employed again, in a full-time role. I argue we have saved this very family from poverty.
Oh, I couldn't agree even more. I really couldn't. I think that what we're doing is, yes, we're caring for the patient at the bedside, but there's such an ongoing roll-on effect of how that affects the family, the place in society and community, people's mental health. They all walk out of intensive care generally with a fair bit of PTSD from what they've had to experience watching their loved ones deteriorate. And I just think that gentle comfort and reassurance that there is somebody qualified and able to help them in the home helps that journey to mending.
Yeah. It's also, the good old term being used in healthcare, holistic healthcare. We're looking not only at a ventilator and a tracheostomy, we're looking at the bigger picture, which includes the family, which includes the social relationships, the family dynamics, everything, where hospitals tend to treat an organ or, bed number 5, whereas we are treating or we're looking after a client and their family from a holistic perspective.
Sometimes even feeding the dogs and the cats.
Absolutely. And I think another thing that intensive care professionals seem to forget is, they can't look outside of their little bed space in ICU. All of our clients, without exception, have community access, all of them.
Yeah.
Absolutely. So you're going from ICU where you're stuck in a bed space or in a cubicle to going home and having community access. especially in the pediatric world, kids going back to kindy, going back to school, whatever the case may be. But, there is a world outside of an ICU bed for those long-term patients.
Yeah, normality. I recall doing that with a little pediatric patient who was a newly after an injury, quadriplegic. And after, I think, about 8 months within the intensive care unit, she was finally at a point where we could take her out on outings. And that family, their first outing, all they wanted to do was go and have a burger at a burger joint and just do family stuff, just laugh and do what they would usually have done prior to the horror that they'd had. They don't want miracles. They just want what they used to have, what they know, when they're, support.
Yeah, absolutely. Now that's, we've shared some similar experiences there, and we can all see what needs to happen for that particular patient group to, improve their quality of life. And in some instances, what we've done as well, quality of end of life, i.e. palliative care, where we've taken, adults and kids home from ICU for palliative care. Sometimes that could have been a few days, it could have been a few weeks, could have been a few months.
Yeah.
Which again, from my perspective, is a much better environment to provide end of life care in.
Yes, absolutely. Yeah. I don't think there'd be many people that would argue against that.
Yeah, absolutely. Okay. And what do you see? I know you probably have less experience in the adult world, mainly pediatrics, but I have mainly experience in the adult ICU world, but it's not dissimilar. It's probably more traumatic for families if there's a child in a situation where they're potentially ventilator dependent, have a tracheostomy. But even in the adult world, there are so many long-term ventilated patients in ICU that, would benefit from going home, and the hospitals would benefit from them going home. Not dissimilar to the pediatric world. Any insights there, or any thoughts on the adult side of things?
Look, I've dabbled a little bit in adult intensive care. I didn't feel it was for me. I think I'm a child at heart, and it's easier to communicate with those that you know. So I didn't find it an area that was conducive to the skill sets that I have. But I still think, at the end of the day, if you're faced with this scenario of lifelong ventilation, or whatever complex care needs that you've developed, there's a sense of mourning and a sense of loss of what could have been. And in pediatrics, that's often exacerbated by the fact that they haven't had as many life experiences. But I still feel like in the adult world as well, most of, a lot of our clients, I think, Patrik, you might have said their average age in their 30s. Is that correct?
I would say, look, I could do the maths, but I would say the average age of our clients is probably somewhere between 35 to 40-ish at the most.
Yeah,
very fine.
That's not a life half led. Do you know what I mean? So there is that the mourning for that loss, for what could have been. However, I think that what we're doing is giving a little bit more sunshine to what can be, rather than just being, stuck in a residential care home, or, where you're outside of your age group, or you're stuck in the intensive care or a complex care ward bed, which seem to be the majority of the alternatives faced by these non-pediatric patients, at least. Yeah.
And what about, we have here in Melbourne, we have provided even home TPN for some pediatric clients. We're definitely doing it for adults. Any thoughts on the home TPN side for pediatrics?
I believe there is a program that does supply that. However, in my age, I've had a lot of experience, and I can definitely recall a young man who, through his disease, was TPN dependent for his entire life. And I think he wasn't. I would have to say, I don't think he was younger than 10 years old when we finally got him home, and the right home TPN care for him to start living at home. And this poor young man had been raised by nurses in the hospital. He didn't last more than a year at home and had to come back because he just didn't cope in the home environment. He was so institutionalized. Wow. It was traumatic. It was really traumatic for all concerned. His parents as well, of course. He unfortunately
Oh,
passed, but that was due to his disease process.
sure. But basically what you're saying here, that every day in a hospital where, especially for long-term pediatric patients, it's really stopping their development as a normal person.
Absolutely, into what they would normally be in that home environment. Absolutely. I mean, the professionals in pediatric facilities do the very best that they can, but it's not a home and it's not a family. No matter what you do, you can't replace that experience.
Yeah. Dionne, I think we also should talk about, from what you and I know about the Children's Hospital in Brisbane, that they tend to ask their families that have long-term ventilated kids to stay within a radius of 30 or 40 kilometers. We believe that with our service, and especially with NDIS funding, that is not necessary. Case in point, in Victoria, for example, we are looking after pediatric clients that are 2-3 hours away from the Children's Hospital in Melbourne, right? We believe the same can happen in Brisbane, that geographically we are not limited. We are absolutely not. We have had, for one particular client, we had a fly-in, fly-out arrangement for staff to go to a remote area, and the same we can make happen in Queensland. And again, with NDIS funding, there's definitely more possible to what I believe the Children's Hospital is offering there at the moment.
Yeah, with Queensland being so geographically vast, I mean, obviously it's a lot bigger than Victoria and New South Wales. I think that as we develop further in Queensland, we will have this as, come to the forefront, that people don't want to move to Brisbane and be constrained by the distance they've got to be from the hospital. I feel like definitely there's a time and a place for that care, that if you need to be near the hospital while you're transitioning out and still have acute care, but the majority of the patients that we deal with are not as acute. They're not as likely for deterioration. They've got, their time on ventilation and stomas and so forth has been to a point where this is, an established care pattern. Let's not make these families uproot their entire lives, move them from their families, their communities, their support people. Let's put them back in their hometowns again.
Absolutely. And I think what, when we sort of talk to people within our world, we're still finding that people don't understand enough about the NDIS as a funding body, as a funding source. What we have found is some people don't even know that the NDIS is funding specialized nursing care like we offer. And this is also for anyone watching this who's an NDIS support coordinator, in case you might have some participants that have only funding for support workers, for basically for an intensive care patient. You should absolutely talk to us, because we wouldn't be talking to you and we wouldn't be in business if there wasn't any funding for nursing care, for specialist nursing care through the NDIS for a ventilated and a tracheostomy client. And if you look on our website, there's a section, the mechanical home ventilation guidelines, which are evidence-based. And you will actually see there that the evidence not only suggests, quite frankly, demands intensive care nurses in the home with a minimum of 2 years, critical care nursing experience to make it safe. And again, case in point, we know of patients, adults and children, that have passed away under the care of support workers with tracheostomy or ventilation because they couldn't manage a medical emergency, which makes perfect sense for anyone that has worked in the intensive care world. So just be very mindful as an NDI support coordinator, what your client needs. And we would love to talk to you. If you have a client that needs the specialist level of care, we can provide you with a nursing assessment. We can also help you with the advocacy with the NDIs, because we've been there, done that many, many times. Now, another thing that I quickly wanted to talk about, Dionne, especially in the pediatric world, and I can tell you from my experience, what sort of conditions we have been looking after, especially with pediatrics. Can you talk about the conditions that you think most of our clients would benefit from our service?
Look, I think there's definitely the syndromes, so like central hypoventilation syndromes, syndromic situations where children are born with, diaphragmatic hernia that is not repaired to the degree that they can survive without, say, ventilation overnight or while they're sleeping. Definitely children with MND, SMA, or the different spinal atrophy type scenarios. Unfortunately, those little people end up usually requiring some sort of non-invasive or invasive ventilation during their disease progress. Lots and lots and lots of children over my career that I've looked after that have got tracheostenosis and, you know, damage to the trachea through ingestion. So a lot of those little people grow and live, you know, relatively long lives, given they still have these things. I recall when I was a baby ICU nurse looking after a newborn baby with it's like a neurological disorder that grew tumours, and their tumour was squashing the windpipe. And that young man came back at 16 for some kind of follow-up surgery, and it was mind-blowing to me that I looked after this little baby, and this big strapping young 16-year-old, he still had his trachea, he still had the actual disease process, but he was living his best life. And that was really through the advocacy of his mother actually demanding that not only that she was given proper training and given proper support in the home environment, this was back in the day, mind you, but also she set upon herself to go to the regional and rural hospital facilities that were close and train the nursing staff there on caring for the specific needs of her son. So, you know, it really can make a difference.
Yeah, absolutely. And, you know, for any parent watching this, you know, I think it is also important, you know, we want to also empower you as a parent, because, you know, we don't want to have anyone bogged down by the system or by the NDIS potentially telling you, oh, you can't have a registered nurse. Well, there's enough clinical evidence that your child or your family member does need and will get funding for a registered nurse to leave intensive care or potentially another hospital bed where you're stuck because you have a tracheostomy or a ventilator. Don't be bogged down by what the system is telling you. Start talking to us. We can walk you through the process step by step, because we've done it many, many times.
It's even the clients, Patrik, that don't have a ventilator or trachees, but they have a complex seizure disorder. That means that during their recovery process or even in their management of that seizure, that they lose their capability of maintaining their own airway. I mean, that is just hands down, you know, an extremely critical moment in that little person's recovery time, that somebody qualified and experienced in doing that. And, you know, pediatric ICU nurses that I've worked with, quite often it would be a daily occurrence for some of our patients that would come in, being able to manage that emergent situation, keep you calm, keep you cool, know exactly what you're doing, and work through that until the patient has recovered fully and no longer has an airway, you know, assistance requirement. Registered nurses are needed for that. Bottom line,
absolutely.
Critical care ones at best. Yeah,
no, that's absolutely true. And, you know, maybe just to illustrate what you've just said, we have a client here in Victoria who's got Rett syndrome, RETT. She's actually not ventilated, but she has still a critical care nurse 24 hours a day. And the simple reason for that is she has regular seizures, unfortunately. And she also stops breathing quite regularly. And when she's seizing, she sometimes vomits. So she's at high risk of aspiration, right? Mm-hmm. And more than once she did aspirate when she has a seizure and vomits, you know. Mm-hmm. So like you said, yes, whilst we are predominantly specialized on ventilation, tracheostomy in the home, there's the exception to the rule where you might think, oh, my child, my family member doesn't have a ventilator, doesn't have a tracheostomy, but they might have complex seizure management issues. They might have an unstable airway even without a tracheostomy, right?
There's also that group of clients, Patrik, that we look after that are, whilst they have a ventilator in the home, they're on a slow wean program. So the doctors have decided that they won't need that ventilator forever. And so we help them by slowly weaning over a long period of time, but in the home environment where everyone can continue to try and live their normal lives. And then when the person's ready, they can go back to the hospital environment, have their tracheostomy removed in the safety of the hospital, and, you know, their post-care is done. And then we don't, you know, quite often we don't need to do much more care for them at intensive care at home as such. And that's really a positive outcome.
Yes, absolutely. I can give 2 case studies here as well. So we've had there would have been 2 18-month-old babies at the time. Both were prem babies, and they spent their first year in NICU and then in PICU with a tracheostomy on a ventilator. They then eventually went home with our service. Both would have been weaned off pressure support at home, and about 6 to 9 months at home, they would have been decannulated. Right. So real success story. Absolutely. Or success stories, again, if you're watching this and, your baby or an adult patient as well is a slow respiratory wean, meaning it's slow to wean them off the ventilator, you should absolutely contact us. Or if you're a hospital, if you're in ICU watching this, you are in a situation like that, your beds are full, you need empty beds, please contact us. We can help you with all of that.
Absolutely.
Yeah. The other thing we should mention now in Queensland is we are now also on the preferred provider list for NIISQ, which is the motor vehicle accident insurance in Queensland. So, if you're falling under that scheme and you need help, you can contact us as well. Dionne, I think any final words?
No, I'm just loving my job. I'm happy at work. This is a dream come true. And everyone that I've met within the company are extremely happy and positive people, and it's a nice environment to be in, and thus hopefully it's a nice environment for all of our clients and their families to deal with as well. So thank you again for the opportunity.
Yeah. No, thank you. It's great to have you on board. And you're coming with so much industry insight, and I guess you're just connecting the dots. Or I think we're all in our world, really, we're just connecting the dots. We're all intensive care ED professionals, just connecting the dots, seeing what works in a hospital, but also seeing what doesn't work in a hospital.
Yes.
And filling the gap in the community. I mean, that's at the end of what it's all about.
Yep, absolutely. I agree.
So thank you, Dionne. We're very lucky to have you. Dionne, how can people find you?
So they can contact me on my email, which is dionne@intensivecareathome.com, or they can contact me on my phone number, which you're going to ask me. And I don't know. I hear it. Sorry. 0436 417 225.
That's wonderful.
Yeah.
That's wonderful. Okay. Well, thank you so much, Dionne. Now, if you are watching this, and again, if you're an NDIS support coordinator and you know of participants that can benefit from our service, we encourage you to reach out to us. If you are a health professional working in intensive care or in any related specialties and you need help with freeing up your exit blocks, please contact us at intensivecareathome.com. Call us on one of the numbers on the top of our website or send us an email to info@intensivecareathome.com. If you are a family member or a patient yourself, you are stuck in ICU and you can contact us, please do so. If you're at home already and you are now wondering whether you could have and need more support, I encourage you to reach out to us as well. If you are a critical care nurse with a minimum of 2 years ICU or critical care experience looking for a career change, we have jobs in Victoria, New South Wales and Queensland. Please contact us as well. If you are an intensive care specialist or ICU consultant and you're interested in our work, I encourage you to reach out to us as well. If you like the video, give it a thumbs up, subscribe to my YouTube channel for regular updates around the topic intensive care at home, and share the video with your friends and families as well. Thank you so much for watching, and I will talk to you soon. Take care.
Bye.
Bye.